We have Dr. Rahul Kakran as our next presenter for his complex knee reconstruction.
Thanks, everyone. Good morning. My name is Dr. Rahul Kakran. I'm currently working in Yashoda Group of Hospital as senior consultant. So this is my case. He was a 42-year-old male. He presented to us with a simple injury of slip and fall at home to the poliotic left side. So he was a known case of poliotic left lower limb, and he had injury to the same left side, which occurred 4 to 5 days back. So when he presented to us, he had a complaint of painful, swollen, and unstable left knee. He gave the history that he was walking prior to the injury without any caliper or without any support. So he was limping, but he could be able to walk. So this is the pre-op X-ray of this patient. So could anyone appreciate anything? It's a simple looking fracture. I don't think, can anyone comment?
We can see the osteopenic bones just because of probably disuse.
Yeah, it is a simple looking X-ray. Nothing much could be appreciated. But so how to proceed further with this case? Because patient was at home for 4 to 5 days. He had a complaint of that he had pain, and it was an unstable knee. So every time he was flexing, he was not able to bear any weight, and every time he was flexing, it was giving a feeling of giving away. So when we examine this X-ray, especially the lateral view, and if we can zoom, we can see a small line that is going from distal femoral condyle towards up. It's a very faint line. So we thought we should get a CT done in this case. So anyone would like to get any other investigation in this case? Or CT will be sufficient? Or do anyone want to just put a plaster and send him away? Because this could be one of the treatment. So we went ahead and we got the CT done.
So can you tell us your clinical findings at this point?
Clinically, it was painful, and it was a poliotic limb.
Of course.
So you cannot assess much because the power was only 3/5. He was walking without any support, but he was...
I mean, since you said it's unstable, can you tell us which plane was it unstable? What was your suspicion?
See, because if it would have been a normal knee, you could have assessed more better.
Sure.
It was a painful knee, and as such a poliotic limb, you cannot assess the actual strength. So it was very difficult for us.
Okay.
So it was a lax knee, but he was saying that every time he's flexing, it was giving him a feeling of giving away. So, but we could not assess because it was very painful. So every time we tried to assess the examination, he was saying, please don't touch it. It was a solid knee. So we got the CT done, and you can see a very faint line along the medial femoral condyle. Do you want to treat it conservatively? It is a medial Hoffa. Or do you want to do anything further? Fix it. So how many people around here would like to
Can we see a raise of hands for people who want to fix this?
Okay, good.
Okay. Do we want some more information out here?
So this is my ARS1 question. Can somebody put the ARS first question?
The question, please.
Yeah. No.
Yeah. So
I will show in a while. So this is the ARS2 basically, but okay, fine. I think we have to post it again. This is the ARS2 question. Yeah. So this is not the ARS1. Can you put the next question, which is the ARS1?
can we have the timer on, please, for this question?
Please. So this is the ARS1 question. So why do you think that non-operative treatment is unreliable for this medial Hoffa fracture? Yeah, Raj, the answer is C, because there is a lot of shear forces. So it would always be better to fix it. So since the patient was very intelligent and he was giving a complaint that it is giving away every time he is flexing. So we got even the MRI done in this case. These are the images, and I will show you the video as well. Can you play this is the MRI. So you can see the faint line, middle Hoffa's, and there is an ACL tear. Then the third video, can you play the third video? The next one. Yeah, this one. So here you can see the anterior horn of the lateral meniscus is also torn.
Do we have Dr. Thiago here? I bet he's looking at the slope also. Dr. Thiago has the largest, the longest published
And
series for
can you
slope change osteotomies in the world.
This video there.
Yeah, that's a tough case.
Thanks for appreciating.
So firstly, a lot of concerns about graft.
Yeah.
I will never touch this leg to get any graft for a leg with polio. I will try to use allograft or maybe approach the other leg. Was the other leg normal, right? Yeah, that's the first question, first point.
So let's just summarize out here. The patient is poliotic. It's a precious limb. He has a lateral Hoffas which is undisplaced.
Medial Hoffas.
Medial Hoffas which is undisplaced. Then he has an ACL tear.
Yes.
He has an MCL tear, right?
Yes.
This is all that we have, and it's
And lateral meniscus, anterior horn and body tear.
fine. And it's an acute injury, correct?
Yeah, 5 days old.
5 days old.
Yeah. So this is the case.
Sorry,
So what's the plan? So how would everyone would like to approach? Do you want to do stage-wise, what to approach first, and how to go about it? Anyone in?
Or if of the Hoffa fracture.
Sorry, how was the lateral meniscus?
This
Can we
is-
have again raise of hands for the Hoffas after these images? How many of us would like to fix this Hoffas now?
So I'll just fix the Hoffa fracture, first stage.
Dr. Shekhar, you want to deal this patient in 2 stages. First stage is fixing the Hoffas, and
Yes.
you'll wait to see what in the second stage?
So you let it heal.
The
See
Hoffas.
this, yes. See, the patient is already poliotic.
Yes,
So that limb is already compromised.
yes.
Okay. And you first let the fracture heal.
Would you not want to fix the medial side and give him a coronal stability with the Hoffas and then leave him in the first stage?
See, you need to have a proper base first, over which the ligament will heal.
Okay.
So once you are having a unstable base, there's no point reconstructing MCL. So
Great.
first you need to fix the structure, the foundation.
Good.
And what would be the sequence if once you fix the Hoffas? Would you like to do it arthroscopically or would you like to do
Then
open?
Hoffa is
Open.
with plate.
And then what would be the next sequence? Like then
Then you let it heal and then examine the patient.
and again, okay.
Yeah.
How much lax was the MCL intraoperatively?
Intraoperatively, it was lax.
Because the MRI showed a very little signal on the femoral side.
Yeah.
The MCL did not look badly injured.
No, but it was opening maybe because of the muscle imbalance. But
Maybe
it was
because of
opening.
poliotic, the MCL did not look to be bad on the MRI images.
Yeah, but even what I'll show, but after fixing even the ACL reconstruction, I could assess, and there was a MCL laxity as well at that time also.
We have, yeah, sir, please.
The patient has got poliotic limb. Is he weight bearing on the limb
Yeah,
normally, or does he have a hand to
he gave this
maybe-
particular history that he was walking with a limp, but without any support. He was not using any caliper. He was not using any a walker or anything. No hand to negate. He was walking with a limp
He has a
before.
good quadriceps power.
Yeah, but there was a limp. He was saying that he could only limp. He could not do the SLR. He categorically told us that he could not, before the injury, he could not do the SLR, but he could walk.
I would like to be careful in treating polio patients, especially. Don't do in a single stage. So do always just fix the fracture and see, observe.
Yeah.
There's tendency to go for non-union and all those things. Once the fracture is healed, then you can think of
So,
this thing and keep non-weight
right,
bearing.
sir. Point well taken.
Dr. Thiago?
Actually, I would fix the fracture and brace the knee again and give the chance to heal. And those patients, they normally have a huge knee hyperextension. I don't know if the ACL reconstruction gonna work because they normally have usually more than 10, 15, even more knee hyperextension.
So,
Excellent. Any other point from the floor? We've got enough time for this case. Is anybody thinking of doing something to the ligaments in the first stage? Anybody from the floor? Is anybody having a thought of using synthetic ligaments for this precious limb? Anybody has this thought crossed their mind? Wow. Okay.
So when we went to the OT, we had everything in place. We had all the implants available for open fixation, and even we had everything for arthroscopy as well. So we were thinking what to do. So we started with arthroscopy, and this is the intraoperative findings. So we could see undisplaced medial Hoffa fracture. We could see the complete ACL tear, lateral meniscus. We could see the anterior horn and body. I'm sorry, at that time I was not recording because I didn't know how this injury was so rare. So MCL tear was also there from the femoral attachment. So this is the findings that I could see intraoperatively. So what next? So as Sir Shekhar has rightly said that we should get the bone first. So we should address the fixation Hoffas first, and then we can plan ahead about the ligaments. So this is what I did. So can I have the ARS2 question? Can I have the question, please? Before this, can I have the question? So not this one, the other one. Can you put the other question? So basically the other question is, what type of injury would you classify this? There is a medial Hoffa, there is a ACL, MCL, and there is a meniscus injury. So what kind of injury, how do you rate this injury? This is basically a complex orthogonal injury. Why? Because there is a complex of forces that is happening in this injury. That is valgus, there is rotation, and there is a shear. So it is a complex orthogonal injury. So can I have my next slide? So this is what I did. So I did the arthroscopy from the standard anterolateral, and I used modified inferior anteromedial portal. First I reduced the medial Hoffa on the arthroscopy and fixed it with Harvard screw, AP direction, and then I used the peroneus graft from the other limb, healthy limb, and did the ACL reconstruction. I fixed the femoral side, and I passed the graft from the tibial side, but I didn't fix it at that moment. Then I did the meniscus repair from outside in, and MCL repair with anchor suture in the same sitting, augmented with the semitendinous graft under the sartorius fascia. So I did everything in the same sitting.
So these all grafts were from the same limb?
Peroneus from the other side, healthy side, semitendinosus from the same side, ipsilateral. I just rerouted it.
When you were planning to open for MCL repair, wouldn't it be helpful to reduce the Hoffas under direct vision when you're opening that?
If I would have faced any difficulty, I would have definitely, because it was an undisplaced fracture. So, and the visualization was so easy, it was just in front of me because I used the modified inferior anteromedial portal. I'll show it because it's just in the same line. I would have made my surgery more difficult if I would have used the MCL incision to fix this medial Hoffas. Yeah. Yeah, CT you can see. CT image is there. I'll have my slide here.
At the edge. The two Herberts are at the edge of the fracture.
Yes.
So I was a bit concerned about the stability in this.
Yeah, this is a Hoffa, and I'll tell you why this portal helps to visualize it further. I have a slide because it will give you a direct view. I'll just show you my slide. So this is the intraoperative image. So you can see the Herbert screws, two placed. And this is perpendicular to the fracture line that was showing in prior pre-op x-rays, even the CT. Okay.
So that endo button is of ACL, right?
Yeah.
On the anterior cortex.
Yeah. And the reason I would tell you why it is anteriorly, ideally it should be posteriorly because of the portal. And I'll show you in my slide. So the post-op protocol was the same. I braced it for 2 weeks. Range of motion exercises was started. Non-weight bearing for 6 weeks and full weight bearing at 4 months. So this is the post-op day 1. This is the brace. Patient was made to stand, and ROM according to the pain. These are my incisions. This is the 2-month post-op X-ray. He is doing fine. This is the 4-month post-op X-ray. The fracture has united.
Can we just stop here?
Yes.
This was ACL, you said, correct?
Yes.
So the tibial tunnel, are we all okay with the tibial tunnel?
It's basically, you can see the tunnel is anteriorly. If I have the pointer, the screw is posteriorly, but the tunnel is slightly anteriorly. But it should have been much better had it been towards the spinous process and more anteriorly. I get it. This is the 4 months post-op clinical image. This is his walking video. So he could walk with a limp. He could walk. There is a limp, but he could walk. And he said the same. He was satisfied because he said I was able to walk. There was a limp, but I was not using any hand or knee gait. I could walk.
This is 4 months post-op.
Yeah, 4 months. So outcome is radiological union by 4 months. There is no subsidence or infection. Range of movement was about 100 degree at 4 months, and full weight bearing was achieved. Now decision. See, medial Hoffa fractures, they are easily missed. CT and MRI are mandatory. Non-operative management has poor outcomes, and arthroscopic reduction in internal fixation allows minimal soft tissue damage, and you can even deal other injuries associated with it. So then I went back and searched the literature. There were only 2 articles that I could find, and both from India, and they were talking about that Hoffa's fracture, they have associated ligamentous injuries, more of ACL avulsion, PCL avulsion, or quadriceps tendon or patella tendon. But they were more of lateral Hoffa's, because medial Hoffa's as such is very rare. So these are the 2 articles. However, they never mentioned how to treat them in these articles. So one was published in 2018 and another in 2020. So why this case is unique? There is a polytic limb. There is a medial Hoffa fracture line. It is going from, as you can see, the whole fracture line can be seen going through the hole. There is ACL, MCL, and meniscus injury, and everything was done single stage arthroscopy. Now, see, that is what I was saying. The endo button was more towards the anterior cortex, because I used a portal which was modified inferior anteromedial, and then the trajectory becomes like this. The Harvard screw I could place because they were perpendicular to it, and the endo button is towards the more anterior cortex. Now this approach, it helps to deal in many ways, because you can better visualize the medial Hoffa fracture. You can place the Harvard screws perpendicular to the fracture line. The femoral tunnel lengths, they are also increased because of this. And when you are dealing with multiligamentous injury, if you keep your tunnels toward the posterior femoral condyle, then there is higher chances of convergence. So if you use this approach, you will reduce this chances of convergence. So what are the challenges in polytic limb? There is higher osteopenia, there is abnormal biomechanics, there is muscle imbalance, and it requires meticulous planning. So fracture heals rarely. So these are the learning points. You can use CT and MRI. In such cases, you can deal it with single stages, although people may disagree. And you should always have a plan open as backup. It's an extremely rare injury. Fully arthroscopic single stage management can be possible, and there's a good functional radiological outcome, and it is a promising option in selected patients. Thank you.
Great case, Dr. Rahul. Thank you for the presentation.